Mental maps, glandular epithelial anomalies, and the importance of differential diagnostics. Dr. Claudia Angelica Peña, pathologist graduated from San Jose Hospital, Bogotá, Colombia, FUCS, PhD in cytology. Visit my website www.educandome.co. Mind mapping is necessary to diagnose mainly differential diagnosis in medicine, pathology, and cytology. The presence of glandular epithelial abnormalities, unconventional as well as liquid-based cervical cytology, often causes difficulty for morphological interpretation, for these anomalies are associated with various benign and malign processes of the epithelium of the endocervix. Amongst endocervical lesions, there is a benign group with morphological, architectural, and cellular similarities with neoplasia, adenocarcinoma. To help in its differential diagnosis and to show the course followed by this topic research, here we review neoplasia-like lesions, endocervical dysplasia, and in situ adenocarcinoma. Glandular lesions. Let's review the facts. AGC comprises a very small percentage of all PAP results, 0.05 to 0.8%. AGC on a PAP test represents a significant risk of a pre-neoplastic or neoplastic lesion, 10 to 39%. AIS, glandular counterpart of CIN3 and the direct precursor of invasive endocervical adenocarcinoma. Precursors of AIS, i.e., low-grade glandular dysplasia, is not well defined and thus not accepted as a distinct histology or cytology entity. Atypical glandular cells. Quality control, quality assurance. 1. Prevalences of AGC less than 1%. 2. Clinical history. 3. Communication. 4. Criteria application. 5. Retrospective review. 6. Cytology, histology correlation. Glandular epithelial abnormalities. Atypical. Specify if endocervical, endometrial, or glandular cells. Specify endocervical and glandular cells with qualifier. Favor neoplastic or NOS, or add a comment. Endocervical adenocarcinoma in situ. AIS. Adenocarcinoma, endocervical, endometrial, extrauterine, NOS. Here we have images of normal endocervical cells. EC adenocarcinoma in situ. 1. Hyperchromatic crowded groups. 2. Increased nucleus to cytoplasmic ratio. 3. Nuclei large, 75 UM2. 4. Even chromatin with coarse granularity. 5. Micronucleoli. 6. Rosettes. 7. Feathering. 8. Strips with pseudostratification. 9. Mitosis. Apoptotic bodies. 10. Amphophilic granular cytoplasm. 11. Clean or inflammatory background. Adenocarcinoma in situ. Here we have images showing you the adenocarcinoma in situ. First image, histology or AIS. Second one, loss of honeycomb feathering. Next one, rosette with coarse granular chromatin. Down to the left, palisading on LBP, then bird's tails on LBP, and last one, rounded endocervical cluster on LBP. Endometriode AIS. Smaller cells than usual type AIS absence of EM, stroma, and stromal fragments, most commonly means AIS. AGC is acceptable. Now we are going to compare HSIL versus AIS. So let's look at the features. Strips and rosettes. They are absent on the HSIL and present on the AIS. Gland forms absent on the HSIL and present on the AIS. Feathering absent on the HSIL, present on the AIS. Polarity is lost in the HSIL and maintained in the AIS. NU shape, round, irregular in the HSIL and oval cigar on the AIS. Chromatin is coarse on the HSIL and even in the AIS. Cytoplasm is dense in the HSIL and even in the AIS. And the background, we have isolated cells on the HSIL and rare ABS on the AIS. Invasive EC adenoca. Abundant abnormal cells, many features of AIS, macronucleoli, cytoplasm, finally vacuolated necrotic tumor diathesis may be present. In LVP, we have 3D cluster more common. Isolated cells seen, chromatin more open, clinging diathesis. Biloglandular adenocarcinoma usually occurred in younger population. The mean is 35 years. 62% history of oral contraceptive use, usually well circumscribed, minimally invasive, behavior favorable, LN metastasis rare, conservative management con only for pure GR1 lesions with minimal invasion, LVI margins. Atypical endocervical cells, NOS. Endocervical type cells with nuclear atypia that exhibits obvious reactive or reparative changes but lacks unequivocal features of AIS or invasive adenocarcinoma. Non-neoplastic processes that may show atypical changes include repair, inflammation, IUD, radiation changes, endocervical polyps, tubal metaplasia, lower uterine segment areas, stellar reaction, microglandular hyperplasia, IUD. Atypical endocervical cells. Atypical endocervical cells favor neoplastic. Endocervical type cells in which cell morphology, either quantitative or qualitative, fall short of endocervical AIS or invasive adenocarcinoma. Arrangement, sheets, strips, cluster, rosettes. Columnar cell shapes. Polarity maintained in cell cluster. Palisading pseudo-stratified nuclei with feathering, hyperchromatic nuclei with evenly distributed coarsely granular chromatin. Mitosis, apoptotic bodies, and C ratio increased. Cytoplasmic mucin decreased. Clean background. Examples of atypical endocervical cells. Favor neoplastic. Causes of AGC. Sampling device, voracity of the sampler, anatomic consideration, benign pathology processes, neoplastic processes. Cytology mimickers of AIS AGC. 1. Abundant normal endocervical cells. 2. Microglandular hyperplasia. 3. Tubal metaplasia. 4. Squamous neoplasia. 5. Endocervical polyps. 6. Directly sample endometrium. 7. Intrauterine device effect. Benign reactive reparative endocervical cells. Sampling device effect. Hyperchromatic crowded groups. EC cells may be pleomorphic, repaired, and adenocarcinoma. Repair can show one or more reactive cellular changes, can involve squamous or columnar epithelium, a sheet-like pattern with distinct cytoplasmic outlines, streaming polarity, and typical mitosis distinguished from high-grade lesions, nucleoli often seen, LBPs, rounder cell groups, less streaming nuclei are more prominent. Tubal metaplasia. Benign metaplasia or EM and upper EC canal. Architectural mimicker of AIS. Planned nuclear features. Columnar endocervical cells in small or often pseudostratified groups. Nucleate round, oval. Chromatin evenly distributed, nucleoli no prominent, mitosis rare. Presence of cilia, terminal bars characteristic. P16, Ki67, NEG or spotty plus. Tubal metaplasia cytology features. 1. Incomplete feature of AIS. 2. Chromatin. Texture distribution. 3. Nucleate washout. 4. Nuclear pleomorphism. 5. NC increased. 6. Mitosis. Rare apoptosis. 7. Large strip nucleate. 8. Cilia terminal bars. Squamous neoplastic mimickers. 1. Most common cause of EC atypia. 2. Most common with brown brush. 3. Involvement of EC gland necks. 4. Learning curve. Squamous neoplastic mimickers may see 1. Groups of cells with glandular architecture, palisading pseudocolumnar. 2. Nucleoli. 3. Granular cytoplasm. Look for 1. Syncytoid groups. 2. Opaque hyperchromatic nuclei. 3. Glassy eosinophilic cytoplasm. 4. Individual dysplastic squamous cells. 5. Lack of typical EC architecture. Endocervical polyps. Common symptoms of bleeding, surface ulceration, EC proliferation, abundant cellularity, HCGs, reactive changes, enlargement, nucleoli, mitosis, inflammation, reparative changes, degeneration, abnormal chromatin, can mimic EC or EM neoplasia. Directly sample endometrium. Tight groups, ACG or two-dimensional sheets, small reniform nuclei, small nucleoli, wispy glandular cytoplasm, cytoplasmic vacuoles rare, tubal gland formation, mitosis apoptosis, cell size smaller than AIS. Reactive cellular changes associated with IUD. Glandular cells, singly or in cluster, resemble a normal endometrium. Three-dimensional vacuoles, enlarged nucleoli. Breakdown. Cytoplasm variable, often Senate ring. Nuclear degeneration, nucleoli. Calcifications. Metastatic tumors. Rare metastatic malignancies, ovary, endometrial, breast, small cell carcinoma, squamous, neuroendocrine, lymphoma. Other serious carcinoma, adenoid, cystic, colon. background clean unless there is direct extension of tumor. Thank you for your time.